Well, hello, everyone. Thank you for joining us for the inaugural webinar in our Cerebra Sleep Science seminar series. Go ahead and say that for you 7 times. My name is Dr. Amy Bender, and I'm the Director of Clinical Sleep Science at Cerebra and your host for today. We are very excited to have you here today as the Cerebra Dream Team will take you through 5 original abstracts from our own Cerebra data and technology featuring the Cerebra Sleep System and the odds ratio product. Our clinical sleep science team at Cerebra is still in its infancy, with me having only been here for 16 months, Basola in second place with 12 months, and then Carrie and Heather only about 10 months. In that short amount of time, we've been able to accomplish a lot with 11 different abstract submissions to 4 different conferences, several research studies, including 1 international clinical trial, a Young Investigator Award for Dr. Lambing, and the ASM Sleep Disruptors first place winning contest for our submission, putting the sleep back into sleep medicine. I'm extremely proud of the team. So without further ado, let me introduce you to them now. Dr. Carrie Lambing will be presenting What Are Home Sleep Apnea Tests Missing? A comparison of respiratory events and OSA diagnosis across type 2 and 3 sleep studies. Carrie completed her PhD in psychology, specializing in behavioral and cognitive neuroscience at Brock University. She has been an integral part of the clinical sleep science team, especially when it comes to helping us run our study smoothly, and also all of the abstract submissions that we're going to be sharing with you today. The team will brainstorm ideas, Carrie will go kind of crunch the numbers and then deliver the good news that we have an amazing result. And I've never really described a person as being like Santa, but that is what she is at Cerebra. We're always excited to see what goodies and results she brings. Second, we'll have Heather Thompson. She'll be presenting the success rates of 213 self-applied type 2 PSG studies. Heather joined the Cerebra customer success team as an RPSGT and has been in the sleep field for 15 years. Prior to joining Cerebra, Heather worked at the Isaac Walton Killam Hospital for Children, where she initiated the first pediatric polysomnography program in Atlantic Canada. And Heather is the sunshine to Cerebra. She's always happy and willing to give you everything. Basola Arayibi will be presenting the feasibility of research using in-home PSG for 20 nights across 24 days. Basola received her master's degree in public health in 2017 and has a certificate in population health. She was instrumental in helping collect data for the study she will be talking about today. At that time, we were a team of 2, and it was just the 2 of us trying to run our first study at Cerebra. So it wasn't easy getting that going, and she was very instrumental in helping that study work. And I would also say that Carrie and I aren't the most organized people. I would say I'm probably the worst culprit, but Basola is always there to keep the kooky scientists organized and in line. And then I'll be presenting 2 abstracts, one on night-to-night variability in ORP and another abstract on using ORP as a marker for insomnia. Before I pass it off to our first speaker, I just wanted to present some housekeeping rules. So we will be presenting those 5 original abstracts, which are 8 minutes in duration, to be precise. We'll have around a 15-minute question period at the end of all the presentations, but feel free to ask your questions as they come in and just put that in the Q&A function, Q&A box. And then definitely check out the Q&A box because you can like the questions, which will then upvote them to the top. So, all right, let's go ahead and get started. The moment you've all been waiting for, the actual presentations. I'm going to pass it over to Dr. Carrie Lambing to start us off.
Okay, so I'm going to be presenting, as Amy mentioned, on what is HSAT missing, a comparison of respiratory events and OSA diagnosis across type 2 and type 3 studies. So in this study, we were really interested in comparing both the diagnostic consequences for respiratory event counts and the resulting severity of diagnosis when we use different types of sleep tests that can be completed within the home. So when someone does have complaints about their sleep and they meet with a medical professional, there are a few different types of tests that they may be referred for. The first is a type 1, and this is really the gold standard for diagnosis. And it measures all of these different physiological signals that are listed here, and it's attended in the lab, and the patient is really closely monitored throughout the night. The second is a type 2 test, and here the patients have the same measurements taken as they do in a type 1, but they get to sleep in the comfort of their own home. And some of these devices, such as Cerebras, are actually able to be self-applied by the patient. And unfortunately, these devices are really currently underutilized in the field of clinical sleep medicine. The last type that I'm going to be talking about today is the type 3. And this is also unattended at home. And because of this, it is really frequently used due to the ability to test a greater number of patients and the fact that it requires a lot less resources on the sleep lab than the type 1 test does. However, the type 3 test does not measure EEG, and so it does not measure brain activity, and it's really focused on measuring different aspects of breathing. And looking at this research and trying to identify how the type 2 can really be used in the clinical sleep market is especially salient right now in the current time with the COVID pandemic. So studies have shown that there are a greater proportion of studies being home studies, since we're seeing larger reductions in face-to-face contact and those laboratory testing. So now that we're having an even greater use of home testing, it's really important for us to be able to look at the different home tests that are available. And based on our industry analysis in Canada, approximately 80 to 90% of the sleep studies that are occurring outside of Ontario are actually type 3 studies. So this is a really common test that's used in the market. And there are several different reasons that we may expect to see differences in event counts between the type 2 and the type 3. So first, when we don't have that EEG, we don't have a measurement of respiratory effort-related arousals included in the number of events, since we aren't able to detect the arousals without EEG. And the second is that when we calculate the AHI, we divide the number of respiratory events detected by the total sleep time. And when we don't have EEG, we have to use total recording time as the denominator, even though some of that recording is going to be time that's spent awake. So since this gives us a larger duration than total sleep time, we end up with a large denominator and fewer ultimate events per hour. So in this research project, we wanted to compare the event counts and diagnosis between a type 2 and a simulated type 3 in the same patients, and in fact, in the same files, to be able to understand what impact that loss of EEG is having on the clinical use. So in this study, we downloaded 550 patient files from the Cerebra portal, and they were complete with their questionnaire data. The questionnaire is focused on different aspects of sleep history and sleep complaints, such as sleepiness. And these PSG files were recorded with the Cerebra Sleep System as type 2 studies. These files were then auto-scored twice. The first time they were auto-scored as they were recorded as a type 2 study, and then manually edited by an RPSGT. The second scoring had the EEG information removed, so we are left with just these channels that are shown on the slide here to simulate a type 3 study. So what did we find? We found that when we compared the type 2 RDI, meaning it included those RERAs, to the type 3 REI at a 3% desaturation threshold, that the type 2 studies, as we expected, had significantly more events per hour, with about 21 events per hour compared to about 16.6 in the type 3. So our next question was, what impact these differences in event counts have clinically? And this table is showing the impact of type 2 versus type 3 on sleep apnea severity. So we have type 2 diagnosis across the top and type 3 down the side. And across the diagonal here, these are the diagnoses that the type 2 and the type 3 test agreed on. And that constituted about 68% of the time. Of particular importance is this group that's highlighted in this blue box. And these are patients that would receive a diagnosis of moderate sleep apnea with a type 2, but only mild sleep apnea with a type 3. And for these patients, having the use of the type 2 might enable them to be eligible for treatment with the CPAP, but the type 3 would not. And that actually was about 15% of our patient sample that may go untreated despite having moderate sleep apnea if they'd only received the type 3. And this figure is showing this in a slightly different way. So it's showing the number of patients who meet the criteria for diagnosis at each of the different severity levels of sleep apnea. So as you can see with the type 3 in teal, we have more in the no OSA and in the mild OSA group with the type 3. But when we cross over this line, which is the line where people typically start receiving treatment, we can see that more of the type 2s are detecting more people in the moderate and severe categories. And this actually coincided with a 41% increase in the number of treatable patients. So the number of patients falling to the right of this line when we're using a type 2 compared to a type 3 study. So what are our next steps? Overall, type 3 devices are focused on the diagnosis of sleep disordered breathing, and they can miss the diagnosis of some other sleep disorders, such as periodic limb movement disorder. So for example, in our study, we had about 3% of the sample with periodic limb movements over 20 per hour. So we really want to look a little bit further into comorbidities in our sample. And we're really interested in investigating that questionnaire data to identify factors that might be especially important in determining who's going to benefit from a type 2. And there has been some research done on this in the past, and factors that are associated with greater wake time, such as age and low sleep efficiency, have larger discrepancies between total sleep time and total recording time. So in this case, these types of factors may be especially important when we're trying to determine if a type 2 or a type 3 study is more appropriate for a particular patient. And one of the variables that we're really interested in focusing on is insomnia-like symptomology, which based on greater wake time, we may expect greater expectancies and ultimately more benefit from using a type 2 study. So overall, we found that the incorporation of EEG into home testing, we find a greater number of patients identified in need of treatment, and the type 2 still has some of the convenience benefits of the type 3 in that it's done in the comfort of the home. And really, when we think about it, the inclusion of EEG is something that's important for when we're measuring sleep disorders, since EEG is really the only way to actually record sleep. And increasing the use of type 2s can help us put the sleep back into sleep medicine. So I'm now going to pass it over to Heather, and Heather is going to be discussing the success rates of the type 2 studies.
Heather Thompson, and I'm an RPSTT at Cerebra. And today I want to talk to you about the success rates of 213 self-applied type 2 PSG sleep studies. So, as many of you know, the wait time for type 1 sleep studies is quite lengthy and has only been made worse by the COVID-19 pandemic. I live in Halifax, Nova Scotia, and here we had about a 2-year wait list prior to the pandemic happening. And I can tell you as a technologist, the majority of the patients we saw in hospital for level 1 type 1 studies were triaged as urgent or semi-urgent. And that meant that many patients didn't get seen, or they would visit our community vendors and have a type 3 study in the field. And some of them would not even see a sleep specialist. As another example, in Manitoba, as of just this past April, 5,355 studies were added to the backlog. And that's in addition to prior to the pandemic when they already had 5,000 studies on the backlog. So that's pretty crazy. And as Carrie just mentioned, 80 to 90% of all sleep studies currently done in Canada outside of Ontario are now type 3 studies, which means we're missing some things and it's not an ideal situation. So the goal of our research was to examine the rate and the type of failures in self-applied type 2 PSG studies, but also to understand like the significance of signal failures at a clinical level. So essentially, can somebody apply these wires at home? Are they going to stay on all night? And how good are the signals on, from a text perspective or from a clinician's perspective? So what did we do? We collected 213 type 2 sleep studies from 191 participants. So each of these participants had the Cerebra Sleep System delivered to their house, and with zero prior training or any knowledge of how to set it up, they watched videos and read instructions, and they self-applied the type 2 sleep test all on their own. Each of these were then assessed based on the duration and the quality of the signals. And a study was deemed successful if either it had 3 hours of good quality data or 4 hours of good quality data. Now, these signals that we collect, it's very similar to a type 1, except that we have the head mounted unit, which you can see on my forehead, that has 2 EEG, 2 EOG, an EMG, and of course the mastoid. And then there's your chest mounted unit. And for this study, we had the nasal cannula and 2-leg EMG. And then of course you had your oximetry on your finger. So now, although little research has really been done on self-applied type 2 studies, we looked at some past research, and type 2 exploration seemed to have a benchmark of looking at 3 hours or 4 hours for their success rate. So we decided to go with both of those and see how we did. And how did we do? So at first glance, we did really well. 82.6% of all the studies were considered successful at the 4-hour criteria, and 85.4% were considered successful at the 3-hour criteria. What this means is that all the wires stayed on. We could look at the data. It was of good quality. It could still be scored perfectly, and it was 3 to 4 hours. So then we wanted to see if it failed, if a study failed on paper, what did that mean? And we found that, as you can see in this chart here, that 56.8% of the time, it was actually just one wire that failed. So what that is, that could be one EEG, it could have been the oximetry, it could have been anything. Now, if there's any technologists in the audience, I can imagine that you're guessing which wires actually failed and which was the most common, and you're probably right. The most common failure was due to the nasal cannula being compromised, 9.4% of the time. And as you can guess, this is also the most common issue with type 3 tests. And it's also even a problem with type 1. Most technologists know how many times they have to go in the room to fix the nasal cannula. But we weren't done there. So after we saw what percentages were passing at our success rate, we wanted to look at the studies that failed and see why they failed and if there were still any data that was worth analyzing. So what we did was we had a technologist look at each study that did not meet the 4-hour criteria for a more in-depth perspective. And as mentioned in the previous slide, it was usually 56.8% of the time just one wire. So what we found was at part of the time, it would be one EEG that was missing or one EOG, but the other channels were of good quality and the study could still be scored. Or perhaps it was one leg wire that was intermittently off throughout the night, but didn't quite meet the 4 hours. Or the nasal cannula failed quantitatively, but when you looked at it, it was mouth breathing, it wasn't great, it could be scaled, and you could still see the respiratory events that were quite obvious. So realistically, it wasn't many studies that were hindered. And in most cases, there was still 4+ hours of data, and the technologists could complete their analysis and report anything that was clinically significant. Now, on top of this, there were 6 studies that did not meet any of the EEG criteria. So the EEG wasn't good, but they could still be scored as a type 3 study, which, is better than nothing because it's all we're doing right now. The one thing I also didn't mention with the Cerebra Sleep System is the validation tests that they have at the beginning and at the end of the study. So when a patient goes home and they apply all the equipment, there's a validation test that is run, and it'll tell you, oh, your nasal cannula is not on, or the EEG is not working, or you need to clean your leg again, so that you know which data, what to fix at that moment. And then in the morning, we know how many, they'll run the validation test again so we can see the hours that each wire passed. So if the oximetry fell off halfway through the night, it might say there was 3 hours of oximetry data, but the patient already has the equipment at home and can easily keep it again. So this will allow the patient to repeat the study, and most issues are usually rectified. So in conclusion, we have found that the Cerebra Sleep System showed reliable performance with high success rates, and that for people suspected of sleep disorders, a type 2 self-applied sleep study provides more detailed information and is a reliable and convenient mode of testing that can help us decrease the backlog. And for most patients, as I think you would all agree, completing a PSG at home would provide much greater comfort. And not only that, the reduced pressure on the hospital system will now open up to type 1 access to patients that have comorbidities that do really require a type 1 study. So for example, those that would require transcutaneous CO2 monitoring and or complicated titrations. And on that note, I am going to pass the baton over to Bisola, who is going to give us some more information on the feasibility of multiple night self-applied type 2 sleep studies.
Thank you, Heather. Hi, everyone. So my name is Bisola, and I'll be talking about the feasibility of using in-home PSG for 20 nights across 24 days. So as we all know, there have been studies that shows how you can do multiple nights, but in the in-lab setting. And so we're interested in using the same technology in home in a complete different environment, and also to use it using the real world conditions. So what exactly did we do? So we had 21 participants who wore the Cerebra Sleep System to record their brain waves, eyes, chin muscles, heart, and then chest effort belt for approximately 20 nights. The intention was to use the device for consecutive 20 nights, but that didn't happen. So eventually it was more approximately 20 nights across 24 days. And so basically what they did was they completed the baseline questionnaire before starting the study. And then every evening, every morning, they complete questionnaire. And then we had a final baseline questionnaire, which was similar to the very first one that they completed. So here are the summary of the variables that we collected. It's quite a few, but for today, I'll be focusing more on the participant retention rate, the number of nights recorded, questionnaire completion rate, and lastly, the skin sensitivities. So in terms of the retention rates, we had 25 people sign up, but 4 people did not even start the study. We had 3 people who withdrew, and then we had 18 people who completed at least 18 nights of the study. Among those who withdrew, we had 1 person complain of skin issues, and so that's why the person dropped off. And then we had 2 people who just along the way lost interest. So number of nights, like I said, we had 18 people who completed at least 18 nights of the recording, and we were gender-based, we were equal, so it was 9 female and 9 males. The age bracket was around 40 years plus or minus 10. And then we had average of 20 nights across the 24 days. So we had someone complete as most as 31 consecutive days. And then the ones we included in the study were 8 at the least. So in terms of the questionnaire completion rates, for the baseline, like I said, the very first one, we had 100% completion rate. For the evening questionnaire, we had 93%. For the morning questionnaire, we had 98%. And then for the final baseline, we had 100% completion rate. So what we did essentially was every morning we checked to see if people completed the questionnaire. If they didn't complete, then we reach out to them and just to remind them to complete. But we were sure to remind them like a day or the next day of the night they complete the study, just so we can capture the most reliable data. In terms of skin sensitivities, we had 39.4% of total nights had reports of skin irritation. I'll be talking more about this in the next slide. But when you go individual based, we see that the reported skin sensitivities were only 36.3% of their study nights. So just to put things in perspective, so people reported having some sort of skin irritation, maybe 6 out of 19 or 18 nights. So it was like a third of the time. And so, like I said, most skin sensitivities were minor. They were very minor. So we had 21%, 27.1% talk about residual stickiness. And this is just maybe, maybe the forehead, and you see some stickiness right there. We also saw redness, 26.1%. We saw 17.5% imprint. And the more severe sensitivity issues were very less common. So we're seeing 3.3% for swelling, 5% for soreness or irritation. So it wasn't that much. And one thing we figured out was the fewer skin sensitivity reports in the evening were reported in the evening more than in the morning. So what was happening is when people wake up in the morning, they might see the redness, they might see the residual stickiness, but by the time they get back home to put on the study for the next day, they will realize that that has subsided. So we can suggest that most symptoms were subsiding during the day. So finally, the conclusion can be said that using PSG to get more accurate data for longer time monitoring is very visible. And one thing you should know is if you're doing that kind of study, people are expected to drop out. There could be some minor skin sensitivities. And like I mentioned before, these are not major issues. They're just like maybe redness, and that goes away, along the day. And also we see that this allows us to have a better understanding of PSG in real-world home settings. And this is what we want, even in clinical research, right? We want to see multiple data so that it would allow us, to diagnose properly, to see the trend of events. And lastly, this will open the door to many new research questions, including how lifestyle factors affect PSG sleep quality. So we could look into like sleep environment, for example. You could look into co-sleeping and things like that. So I'll pass it on to Dr. Bender, who will actually talk about the 99 variability using ORP.
Okay, thank you. Great presentation. Today I'll be talking about, I have two presentations. My first one is focused on night-to-night variability of sleep quality using ORP. So the problem with assessing sleep quality long-term, we do have actigraphy, which is good in the field. It's good for long-term monitoring in a real-world environment. However, there are issues with the sensitivity of that data, the quality of that data. Typically, we're just seeing benefits from getting an overall picture of total sleep time, but there's a lot left to be desired when it comes to looking at more sleep quality metrics. We also know we do have the capability to look at PSG in the lab long-term. So I was a research assistant during my graduate study days where we would do 2-week sleep studies in the lab. But the problem with that is we know that sleep is different there. So the person is sleeping by themselves in the laboratory environment. There's not, for example, potentially a snoring partner or other interruptions like kids, pets, work getting in the way. It's a really controlled environment. And then also there's the issue with the brain being more awake when we're sleeping in a new environment. So there's been some research to support that as well. I think another issue that we have is we don't have a good way to measure sleep quality to begin with when we're talking about kind of these standard parameters and metrics. And so what we're typically used from that PSG is we're looking at sleep efficiency, so the time that the person is asleep while they're in bed. We may be looking at sleep stages, such as the percent of deep sleep or the percent of stage 1, for example, but they aren't really associated with clinical outcomes. And then there's also potentially, slow wave activity, delta powered, which we look at in the research environment, but it does ignore depth of sleep during REM. It's just focused on non-REM. So in the current study, we wanted to address each of those issues by using the self-applied PSG in the home with the Cerebra Sleep System. We also wanted to look at odds ratio product to measure sleep quality. We were interested in 3 main questions for this study. We wanted to know how much did sleep quality vary between people? How much did sleep quality vary within people? And then how many nights does it take to get a stable pattern of sleep quality? So we were interested in, again, trying to get information on my sleep quality versus your sleep quality. with that first box. For the second box, it was related more to how much does my sleep quality vary from night to night? And then in that third box, really focusing on how many nights does it take to get more of this stable pattern of sleep quality? So we had, this was again part of what Bisola was talking about earlier with the 18 participants across 24 days. So we had 18 participants complete 18 to 31 nights of sleep in the home using the Cerebra Sleep System. And we wanted to objectively measure sleep quality looking at odds ratio product, or ORP. So what actually is ORP? So it's looking at microanalyzing the EEG signal. So it's decomposing the waves. So you have a typical EEG waveform. And what ORP is doing is it's decomposing those waves. So it's separating that wave into delta, theta, alpha, beta. So those 4 different components or 4 different frequencies of that wave in 3-second chunks. And then it's taking those denominations for each of those frequencies, and it's looking at the delta power, so the amplitude of that wave, and getting a 4-digit combination. And so then how that's translated into the scale is the probability that someone is awake with those different combinations. And then that's converted into this ORP scale from 0 to 2.5, with more of the deeper states of sleep occurring in the lower values, and more like the full wakefulness or more wakefulness states occurring in the higher numbers here. So sleep quality would be, a lower value would be more indicative of better sleep quality, versus a higher number would be more indicative of poorer sleep quality. And when we look at ORP across the different stages, so in the middle here, we have the different stages of sleep and wake, according to the Rechtschaffen and Kale rules. We do see that there is variation in ORP across even within these stages. So for example, if we look at this stage 2 in the middle here, we see that the ORP on the right is 1.1 in the first epoch of stage 2 versus 0.59 that's still classified as stage 2, but we're able to get more information using ORP versus if we were just categorizing the different sleep stages. So ORP can vary across sleep stages, providing more information than standard staging about the depth of sleep within those stages. So for our results, we had 18 participants complete at least 18 nights, and average age, again, around age 40, with half of the sample being females. We did have fairly, I would say, normal sleepers. So the average PSKI score was about 5.3. Average Epworth Sleepiness Scale about 5.4. We did have a few individuals who were classified as sub-threshold insomnia according to the Insomnia Severity Index. And in general, similar, this is obviously the same data that Bisola presented. So we had 375 nights recorded in the home. On average, people had about 20 nights recorded across 24 days. So what did we find with these results? How stable is ORP from night to night? On average, we saw an ORP value of 0.98. The individual range in ORP across nights was 0.44. And then the between subject variance was 1.4. So kind of what that means, and if you look at this graph, we see all the different individuals in the study along the bottom, and then what their ORP values were here on the vertical axis. And as you can see, we see a lot of variation between individuals across this entire study. And in general, we do see a pattern of more stability within individuals. So, and that's according to the statistics as well. We see small within subject variability, and large between subject variability. Although we do see outliers here within individuals. So these dots here are outliers where the ORP wasn't, there may have been a couple nights where the sleep quality wasn't as good in some of these individuals as well. So how many nights do we actually need to get a consistent idea of pattern? We used a statistical method to capture that. And we found that there was about a mean of 10 nights to get a stable pattern of that sleep quality using ORP. Although there was a range between 2 and 20. So there was a lot of variability within individuals. A couple of people only needed 2 nights to get a stable pattern, whereas other people needed potentially more nights. So conclusions, we did find that subjects had a wide range of between subject variability in objective sleep and a small amount of within subject variability, although we did see some of those outliers that you saw in the graphs. Despite this, we needed approximately 10 nights to get a stable sense of the pattern. And I think this is similar to data that was presented by Lachat recently, where they were looking specifically at variability in AHI between nights. And they found that 1 night of sleep recording was not enough to capture the full sense of sleep problems when it came to OSA diagnosis. Let me grab a drink of water really quick. I'm going to move on to my second abstract, which is a PSG marker of sleep quality using odds ratio product are associated with insomnia symptoms in a dose response relationship. So let's unpack that a little bit. As we all know, as most of us know on the call, we know that the diagnosis of insomnia does not require an objective measure, and that it's currently diagnosed with subjective complaints, and that there is really paucity of research linking insomnia with objective markers. I mean, we do see hyperarousal being seen in the EEG, but there's a lot more to be explored here for certain. And we do see different types of insomnia with objective biomarkers, as I mentioned before. But I think what's really interesting is how can we identify these objective markers of insomnia, which could respond better to different treatments. This is definitely a very interesting area to explore. So our research aim was to assess whether a PSG marker of sleep quality using ORP was associated with the number of insomnia symptoms. So how we did that is we looked at 416 participants who recorded their sleep with the Cerebra Sleep System and also completed questionnaires on their insomnia symptoms. So they reported whether or not they had any of the following insomnia symptoms at least 3 times per week. So whether or not they had issues falling asleep, staying asleep, and then waking up earlier than desired. And they had to, in order to check that box, it had to be occurring at least 3 times per week. We then classified participants based on the total number of insomnia symptoms reported. So out of these 416 participants, how many reported no symptoms, how many reported 1 symptom, 2 symptom, and 3 symptoms. And of course, we're looking at sleep quality was measured using ORP. And in this case, we were looking at ORP across the entire record. So looking at ORP total recording time. So again, I won't belabor this too much because I've already explained what ORP is. But again, just to summarize, it is a continuous measure of sleep depth measured every 3 seconds, and it's microanalyzing the EEG, decomposing that waveform into delta, theta, alpha, beta, and looking at the power within those combinations and converting that into the sleep depth scale, which is from 0 to 2.5, with deeper sleep or better quality of sleep occurring on the lower end, and then more full wakefulness occurring on the right-hand side, the higher numbers of ORP. So what did we find? Well, out of the participants, we were looking at 416, we found 199 participants reported no insomnia symptoms at all. The remaining 217 reported at least one symptom 3 nights per week. So we had about 30% of those reporting one symptom. 38% of those reporting symptoms reported 2 symptoms. And then around a third, again, reporting 3 symptoms. So what did we actually find? Well, looking at, we have average ORP total recording time on the vertical axis here, with higher numbers indicating poorer sleep quality. And then we have number of insomnia symptoms reported along the horizontal axis. So 0 insomnia symptoms reported, for example, versus 3 insomnia symptoms. And as you can see, the values of ORP go up with more insomnia symptoms reported. So we do see poorer quality sleep in those with higher number of insomnia symptoms. So next steps for us would be to explore if potentially treatment interventions aimed at reducing ORP TRT might be helpful to treat insomnia. All right, so I'm going to stop sharing and we'll go ahead and get to the Q&A. So again, remember, definitely utilize that Q&A function, and it looks like we have quite a few questions here, and you can also upvote those questions as well. So let me get started here. It looks like our first question: to what extent can the Prodigy system be used by individuals utilizing a CPAP or BiPAP during sleep? Can Prodigy be used at the same time as a CPAP or a BiPAP device? I think I'll pass that over to Heather, our RPSGT, if you want to take a stab at answering that question.
Sure. Can you hear me okay?
Mm-hmm.
So essentially at this moment, we cannot, not on paper. We have tested on like in the lab just to see if it works. We've had, as you might have used with other level 3s, however, if you hook the nasal cannula or a pressure cannula to the CPAP to the device, it works. You can see the flow, you can look at it, you can score apneas, hypopneas. Now, in terms of actually seeing like tidal volumes and like with BiPAP, the different pressure levels and being able to see that, no, we're not there yet, but I do presume that it will be in the future. That's just, but right now we're primarily using nasal cannula. Hopefully that's helpful.
Okay, very good. Our next question here is, given some of the complexities of performing and interpreting PSG in conditions like COPD, has Prodigy been validated in this population or other populations like obesity, hypoventilation? A great question. I can definitely try and answer that question. So we have 2 studies. Well, one study we just completed where we were comparing the Prodigy device to in-lab PSG. And for that particular study, we did exclude patients with COPD and obesity hypoventilation. So we don't have that data in order to assess how it would work in that population. And we have another study that is about to get started, and we did exclude those individuals as well. So unfortunately, we have not validated in the COPD folks or people with obesity hypoventilation. I think we're starting kind of conservatively by excluding those individuals because we're not sure how that would pan out. But I think for the future, it's something we definitely want to look into to assess, can we assess sleep in those individuals in the home. And that's something definitely we want to check out for the future. All right. I think the next question is, why did you only assess 3 or 4 hour recording durations instead of 8 hours, for example? So I think that question is for Heather.
Hi again. Well, there's two things. So primarily the reason when we're looking at past studies that were even for type 1, for type 3, it seemed that the benchmark for testing was 3 hours or 4 hours. So we were going with that, but also in many provinces and states, 4 hours is the cutoff for saying, okay, this person, you need a 4-hour diagnostic. Now this person could have a CPAP titration. If they had 3 hours, they would have to repeat the study. So we felt that 4 hours would be a good level. Now there'd be nothing wrong with us going for more hours and seeing how it turned out, but that is kind of the benchmark for most research studies.
Very good. Okay, question for Dr. Lambing. What if you compare the AHI? So I know in our study, we were looking at RDI versus REI. What would that look like for the AHI? Does the effect seem to be driven by including RERAs? Great question.
Yeah, so when we compared the AHI to the AHI, so we didn't include the RERAs, it was still significantly different. So we ended up with, in the type 2s, it was about 20 events per hour instead of the 21.1. So it didn't seem like the RERAs were driving the effect. It's more likely the discrepancy between the total sleep time and total recording time, but that's something that we want to look into a little bit further in our data as well.
Very good. Heather, a question for you. How did you choose the studies for testing the feasibility quality? So I know you had mentioned you had 213 studies. How did you actually choose those studies for this particular study?
Yeah, it's kind of an odd number, 213. So there was actually 191 participants, 213 studies. And the reason we had that number is that's how many studies we had that were delivered strictly by Cerebra, not going through another agent. And we wanted to make sure that the distribution process was standardized. So for example, if it was a clinic that was using them, they might have a technologist that are setting up the patients or doing prior instructions. Whereas we know we're shipping the device out, they're doing it all on their own, they're watching the videos, they're sending it back, and we could actually monitor that for standard rules.
Okay, very good. So we have a question for Bisola. What do you think the most difficult part of the study was, in your opinion?
Well, I think the most difficult part was reminding people to fill out the questionnaire. Because usually what happens is they sleep, they wake up, and then they forget to do the questionnaire, right? So we had to like contact them to get them to fill the questionnaire. So if we can develop a system where if they don't fill out the questionnaire, we can send a reminder to them like immediately for them to fill out. I think that would be fantastic.
Definitely. Yeah, a lot of manual checking that you were doing, Bisola. Okay, and the next question we have is, do you know how much alcohol consumption, exercise habits, daylight time, etc., influence the variability of ORP over the multiple recorded nights? Great question. We actually have 2 abstracts that we're going to be presenting at the European Sleep Research Society meeting in September. One of them is related to time outside. So we did, as you might have saw in either Bisola or my presentation, we were asking people about activities that happen during the day. So we were asking about how much alcohol they were consuming, cannabis, others, caffeine, for example, exercise habits, and also the time that they were spending outside. So we have a lot of data to uncover in our European Sleep Research Society abstracts. One of the ones we were focused on was time outside. So we were looking to see how time outside impacted ORP sleep quality and then how that impacted performance. And we did find that the more a person spent outside, and it seemed the sweet spot seemed to be about 2 hours, which is quite a lot. But those people with 2 hours of time outside had better sleep quality, which then led to better performance the next day. So we were looking at performance metric using the PVT, or the psychomotor vigilance task. And we did find that those who were outside had better sleep quality and had better performance the next day. That was one of our abstracts, which is really exciting to link with performance, is really exciting for us. We have another abstract that we're presenting related to caffeine timing that our other RPSGT, Leslie Cervantes, is going to present at the European Sleep Research Society meeting. And we found in that particular study that those who drank caffeine too close to bedtime, so we're talking 4 to 5 hours within bedtime, reported being more awake prior to bedtime, which isn't a surprise. Their sleep quality was poor according to ORP, and they subjectively reported that their sleep was poor after consuming caffeine close to bedtime. And we were able to link that with performance as well. So we're really excited about that. Alcohol consumption, I don't believe we've uncovered the results from that yet. Exercise habits was a little bit, we didn't find a clear relationship there with exercise habits and how that linked to ORP and then next day performance. So still definitely a lot to be recorded or to be explored in that study. And again, I think this second question is kind of related. What factors could be related to the outliers you see in the night-to-night variability in ORP within individuals? I find that part really fascinating, that the pattern is pretty stable, but we do see those outliers in the data. And so really, I think we have a lot that we can do for that, to look at these individuals and see what's going on during those outlier nights. And it could be, we found the effect of caffeine, we found the effect of time outside, but it could be an individual factor for these individuals. So it could be potentially, we didn't find an overall effect of exercise, for example, but for that particular individual, we may see that evening exercise could play a role at making sleep quality either better or worse. And so that's a really exciting part, I think, is to look at it on an individual level to see what's happening in these individuals. And ultimately, I think we'll use that information in developing a digital therapeutic for the future, to really hone in on the individual and how their specific factors are impacting sleep quality. And then at me, so given the 10-day requirement for reliable sleep assessment that you showed in your first presentation, can you comment on the effectiveness of one representative night of PSG in the lab or otherwise, typically used to diagnose OSA? It's really fascinating to me. I mean, even there has been some work, as I mentioned, with Dr. Lachat, where they looked at AHI specifically, and we're actually going to be collaborating with a partner. Now, in Dr. Lachat's study, they looked at an under the bed sensor. So you kind of have to question maybe the reliability of that data. And so we're hoping to collaborate with one of our partners who actually wants to use the PSG Cerebra Sleep System full night study for at least 10 nights. And they want to look at the variability in AHI. So I think with future work, we could definitely get a better idea of what's going on there. But at first glance, even based on our data and the data from Lachat, Dr. Lachat, I don't think one night is enough. And I think in Dr. Lachat's study, I think he found like around 50% would have been misclassified if you are only using one night of testing. I know that opens up a big can of worms when it comes to, affordability. But I think our system could potentially be used for more than one night in the home, as it's a convenient way to do that. What was the ORP value or criterion that had to be achieved for the sleep quality to be considered stable by a certain number of nights? Great question. We did use that bootstrapping method, which is kind of a statistical way of doing that. It's a gold standard statistical way of doing that. So I can't go into the details of that, but it was kind of the gold standard way that you look at stability among a measure. And so that's what we were doing in that particular study. And that's how we came up with the 10 nights. Do you think that certain types of symptoms like trouble falling asleep could be playing more of a role in poor sleep quality? That's a really good question. I think we could definitely, in our particular study, we were looking at number of symptoms, not type of symptoms. And so that would be something interesting for us to look into is, for example, trouble falling asleep kind of a bigger culprit when it comes to these sleep quality issues? Definitely something that we can further explore. Can the EEG, EOG elements of Prodigy be used even if so this is a follow-up, I think, to Heather, the previous question for Heather. So can the EEG / EOGs, elements of Prodigy, be used even if someone is using CPAP or BiPAP? So I think they wanted kind of more clarification on that.
Yeah, sorry. Okay, I think maybe I misunderstood earlier. So for sure, yeah, you could wear your CPAP and then just monitor everything else, and you just wouldn't be monitoring nasal pressure. That would be the only difference, really.
Okay. And Heather, can the EEG, I think similar, can
Same question, I think.
Okay,
Yeah.
got it. Ooh, here's a good question. Do you have any data on ORP in sleep state misperception insomnia? Great question. We do have a data set right now. Actually, it's a smaller data set where it classifies people with insomnia based on sleep state misperception and psychophysiological insomnia. And so this is something we're very interested in exploring. Like, are there different biomarkers? Are there different ORP metrics or ORP values that are different, that could differentiate these two insomnia types? And so that's something, a great question, definitely something we are going to look into. Okay, well, we're here with about 2 minutes to spare, but I think we covered all of the questions. Really thank you for your attention and checking out our abstracts that we presented. And I also want to thank our speakers as well, who did an amazing job. For many of them, this was their kind of first oral presentation in front of this scientific audience. So I want to give them also a shout out. And thank you for attending. And we will stay in touch with further seminars that we have upcoming. We do have a sleep rounds with Dr. Magdi Yunus upcoming on July 19th. So keep an eye out for that. That's where he discusses different cases from the Center for Sleep and Human Performance and how we can use ORP to better help treat these patients. So thank you so much for your attention, and we will definitely stay in touch and keep you updated on any further webinars that we have. Have a good day. Bye.